Welcome to the first episode of the Trio podcast. Heart disease has been the leading cause of death for over a century. Dr. Kim Williams, cardiologist and current chairman at the University of Louisville's Department of Medicine, joins us on this episode to discuss the factors that have made this disease a costly healthcare problem for so long. He also discusses the importance of community intervention in disease prevention and presents us with policy ideas that can play a significant role in improving health outcomes. Together, we debunk common heart health myths, including ones related to having a family history of heart disease, keto diets, and prevention in your 20s. In addition to being the president of the American College of Cardiology in 2016, Dr. Williams has served on numerous committees and boards at the national level, including the American Society of Nuclear Cardiology, the American Heart Association, and the American Medical Association. He is also the editor-in-chief of the International Journal of Disease Reversal and Prevention. Dr. Williams, thank you so much for joining us today. We're super excited to have you on. And the goal with this podcast, as people might have heard in the trailer, is to put individuals back in charge of their heart health and really have them be empowered so that they can, understand and interpret their health data and then take the steps accordingly to improve it alongside of experts. So we're going to start off with a quick 3-2-1. 3-2-1 is just 3 things you personally do to take care of your heart health, 2 things you could be doing better, and 1 thing you wish more people knew about heart disease.
So if I were to start with the 3, it would be whole food plant-based diet. And I really try to do that exclusively. I am very fortunate to have the kind of dyslipidemia, that is elevated cholesterol, that is very sensitive to diet. And I know there are people, they say, they're hyper responders. Well, pretty much everyone is sensitive, whether folks want to, in the certain industries that sell, cholesterol-laden products would have you think that people are not all that sensitive to dietary cholesterol. And then there is a handful of people who are. Well, I am very sensitive. And so, but it isn't just cholesterol, which I haven't knowingly eaten a milligram of cholesterol since 2001 or 2003. But clearly, saturated fat and refined grains and even sugar can raise your LDL cholesterol. And so I've got to, maintain really strict control. So I'd say diet is number 1. Not the easiest thing to do. In modern society, you buy a product and you find out, that's 4.5 grams of saturated fat, put it back, and that sort of thing. The second thing that I do is exercise. And very much, I was a professional tennis player back in the 70s. I had no idea that people my age went to show up for a tournament and there was prize money. So I guess I'm a professional tennis player again. So, except I didn't win any prize money. Beat the number 1 seed, but I ended up losing the next match. But the fact of the matter is, this is a real passion. And that gets over into the third thing, which is mindfulness. Okay. And everybody has their own way, or if they're thinking about this at all, how do you maintain balance? How do you work hard and maintain balance in a tough profession such as medicine? Medicine was tough, and then it became a chair of medicine, and it multiplied by 12. But the issue is you have to find something that you really love. And there's so many techniques out there that have peer-reviewed literature behind them. Yoga, Tai Chi, scripture reading, prayer. In my case, it's a sport, a very addictive sport, which is tennis. And people, if you're reading the British Medical Journal, you've seen all this stuff about mortality benefit of tennis and racket sports in general. But tennis, it's a 17-year increase in life expectancy. Whole food plant-based diet is only 15. So I'm hoping that they're additive, of course. And so I will win a USTA title for 95 and older. We'll see. So those would be the big three. The two that I could do better, one would be sleep. It is hard to, I always, say that the good part about being chair of medicine now, as opposed to a chief of cardiology, is that I work 18-hour days. But with the exception of the president of the university, the provost, and the dean, I get to call the 18 hours. So I can decide when am I working, when am I, playing tennis, and I could consider that part of my profession too, by the way. And so sleep has been added. For those who didn't hear last year, to the American Heart Association Life Simple 7, it's now Life Essential 8, because the criticality of good sleep in terms of regenerating your brain. There's a lymphatic system in your brain that regenerates and cleans out your brain. And if you don't sleep enough, that's not happening. And people who, there's all this data about if you sleep too much, that it increases mortality. That might actually be reverse causality, because you can never control every variable in those kinds of observational studies. But the fact is, if you're sleeping more than 8 hours, you might be at risk. So that would be the kind of thing that I would like to see myself do better. It's never too much. It's always on the too little side, trying to get too many things done. Yeah, I would struggle to find another one that I'm not doing, because I try to do everything that's evidence based. So if I had identified it, I would have fixed it already, I think. So I might have to take a pass on that one.
That's fine. That's really good.
The last one,
Yeah, one thing you wish more people knew about heart disease.
I would say, as hard as it is to admit, and obviously with your audience, we're probably preaching to the choir, but it goes for everyone who's out there in the audience. There's somebody that they know who doesn't understand this. And that is, the vast majority of the time, doctors, nurses, patients, nutritionists, dietitians are eating things that are known to increase mortality. Why can't we just educate ourselves and make choices that are not going to not only shorten our life expectancy, but increase our chronic illness and increase our healthcare budget dollars spent on really unnecessary suffering and illness? 80% of our budget, and it's over $1.4 trillion, I hear, diet-related diseases, chronic illnesses that would be prevented, mitigated, lessened, eliminated if people were to eat a whole food, plant-based diet and exercise every day. So what I'd really like everyone to understand is lifestyle medicine is real. And all of those, those 6 pillars, and making sure you're not doing substances, and making sure your blood pressure and your weight, your blood sugar, all those things are really good. Making sure you're sleeping, but having a whole food, plant-based diet is the key to success.
What I find really insane, I guess, is that this has been the leading cause of death for like a century. If you had to summarize how you think this became so common, what would you say?
Yeah, it actually is, the development of affluence. And when people had to grow food in the ground and rely on them, on that, uh, the health was better. You can't, the life expectancy wasn't necessarily better, but the development of coronary artery disease and hypertension, diabetes, our obesity epidemic, all of those were better. Now, you could argue that we've developed our society and our medical system of care so well that we now suffer from, diseases of opulence. And there's some food insecurity, no question, in this society that we have in the United States, and certainly around the world. But it's not like it was in previous centuries. And with the Industrial Revolution came more sedentary living, jobs that didn't require you to go out on the farm and plow and to eat. And that unfortunately has resulted in less activity and more calories, more obesity, and therefore all of the cardiac risk. So, it's been that way for quite a while. As you mentioned, it was a century. The factoid for people is that it's every year since 1918. 1918 was the end of the World War I and the Spanish flu epidemic. And that really ravaged folks, similar to COVID. If COVID had started in the United States in January instead of February, it would have taken it out in your graduation year, 2020. But it didn't, and so heart disease remained number one. And COVID it wasn't just inflammatory like the Spanish flu. COVID had a lot of different things that it would do with the immune response, and it affected the heart very often, and so it accelerated, heart attacks. So it actually increased our cardiovascular mortality to some degree.
We see that the World Obesity Atlas is off the charts post-COVID, and the numbers, well, these are projections. The projections are not looking good for um, Americans in terms of heart disease as we move towards 2060. I really like this one thing where you said projections only become reality if we allow them to. Major heart health organizations, including ones that you've worked with, have been putting out guidelines for years. What barriers are still getting in people's way in terms of getting to the root of this condition, and especially the
So
preventable types of heart disease?
one of my least favorite topics. Just finished an article. I turned it in for peer review. They'll probably laugh at it, but I call it Chatting with ChatGPT, where we actually did um, a really, like people put an interesting question in ChatGPT and see what it says. So the question that I posed is, if a whole food plant-based diet decreases animal cruelty, stops the erosion of the planet, and improves dramatically human health, why isn't everybody doing it? And it basically gave me 10 answers that are the things that the barriers that you're asking about. Very logical. Some were completely accurate. Some of them were perceptions that are not true. The best example of that one is that a plant-based diet is more expensive. That is just completely not true. You buy beans, grains, nuts, seeds in bulk, it's way cheaper than meat. And yeah, you have to be careful with the vegetables so they don't spoil. But if you have a freezer, things don't spoil. So that one was clearly, and the AI actually did get it right, that this is a perception and it's not a reality. But the other answers are just what you would think. They're culture, habit, social pressure, perceptions, misperceptions about nutrition adequacy. And so, you try to deal with each one of them. So anyway, the editorial is about my response to each of them, how true the answer was, and what are the things that we should know. But commercial entities and advertising, that's a very key issue that we need to deal with, and it's one of my favorite topics. I'd actually written an article that was published in the International Journal of Disease Reversal and Prevention by myself and Michelle Ikram. It's about marketing mortality, because that's what we're doing. And what we did was a study of television commercials. It was actually my granddaughter and Michelle watched them, not me. And over 100 television commercials. What kind of commercials were they? 58% of them were fast food. And then do a scoring system. Is it a healthy item or an unhealthy? So +1 or -1. And when you have a cheeseburger with dairy and meat and a refined grain bun and a large sugar sweetened beverage, okay, and a wonderful potato, that would be good. But nope, they fried it. It's French fries. That's a -5. Okay. And so what are we marketing to kids? And just a little bit of a literature search convinced us that it was increasing healthcare disparities, because it turns out that poor people watch about 10 times more television than wealthy people. And so you end up with, who are you marketing to? Kids and people in poverty, and they're going to go out and they're going to buy the fast food and suffer the consequences and not have the health care or not have the resources to try and balance that out financially. Health is wealth, as I like to say. And the important part is that we have to recognize that medical debt is now the leading cause of bankruptcy in this country. And the medical debt is because of nutrition. So I really think that the barriers are out there, that each one of them can be tackled, but it's going to require education. I say that it's help from our government and regulators, because, I mean, other people, when I was a kid, said you had to have a seatbelt and you had to wear it. But you had to install it in the cars, every single car, and then click it or ticket. And so what happened? You had a lot of unnecessary deaths from car accidents going down. Why wouldn't we do the same thing? Well, the difference is the commercial entities. If you have people selling high cholesterol items as a business proposition, I mean, the only people who were hurt financially by seatbelts were morticians, I think. And I'm not sure their lobby's large enough to change the laws. So we have to make a decision. A decision. What do we want as a society? You want people who, with the decreasing age of the onset of heart disease, which is now, upper 30s, 40s, and 50s. Do we want to erode our tax base? Okay, while our medical system gets so good that we save their lives. And so now they're on Medicaid because they have, New York Heart Association grade 3 or 4 heart failure. They're disabled. They're not working. They're not contributing to the tax base, but they're on Medicare. Same thing with kidney dysfunction, renal dysfunction. All the literature says that it is due to animal protein. Animal protein worsens chronic kidney disease, and particularly red meat, and it ends up causing dialysis. And every person who's on dialysis, it costs Medicare about $100,000 per year. And it used to be they die after 2 or 3 or 5 years of dialysis. Not anymore. Dialysis is really good. Okay, and so they're staying on. Longevity on dialysis is going up, and the expense is going up, and they're usually not working because they're disabled as well. So we have to decide what we want. We want to pour our resources into roads, bridges, and education. I think every uh, um, kid with living in poverty, with food insecurity on the south side of Chicago should automatically get a scholarship. Talking about me, okay, to automatically get a scholarship to the University of Chicago. Okay, uh, we could do such creative things that would benefit the society so much more than what we're doing. Paying it for diabetes and obesity and the like.
Something that was really interesting that you were talking about was when you went to the White House conference on nutrition, and you were talking about like the labeling, like the red, green, and yellow. First of all, do we have numbers on like how effective that has been, and like what else would you add to those initiatives?
Oh, let me tell you about the White House conference. So I was actually part of a group of, there's so many physicians, so many nutritionists, so many people who are dietitians who were participating in conference calls to try to come up with cogent recommendations to give to the White House. The ones that I was talking about, as you mentioned, I wanted food labeling. I wanted getting rid of these television commercials with bad food, particularly in front of children, because Canada's done that. I wanted to change the SNAP program. You can't take away the ability to buy, things like World Health Organization Group 1 carcinogens, bacon, sausage, hot dogs. You can't take them away necessarily, but you could increase the amount of SNAP benefits that they have if they are buying fruits and vegetables. You could do that, and you'd save the money on the other end. We wanted food labelings in the stores, red, yellow, green. Let people know, yeah, that bacon is going to harm your health. It's associated with kidney failure, heart failure, stroke, cancer. Why not let people know? And so what ended up happening with the conference is that I didn't end up going. So I end up giving all those recommendations, and they turned them all in, and but I kept emailing them, why can't I come to the conference? And on the morning of the conference, 2 hours before it started, I got my instructions on how to get through security. So anyway, I clearly have gotten over it. Okay. So, it was just a miscommunication from the staff. So I did, I watched with pleasure to see the POTUS get up there to the podium, POTUS on the podium, talking about all of these initiatives, except the commercial one. He did not mention that, but everything else that I had suggested, he was talking about doing. Community education is so key. People should know what they're eating and the effect that it's going to have. So anyway, bottom line is that I haven't seen, to answer your question, I haven't seen a lot of movement. As you know, there's been a lot going on politically in DC and the White House, and with all of that kerfuffle, I'm not sure. At least we had an opportunity to talk about it and to set an agenda, but it may be, in the purview of future, executive branches to get that agenda into the legislature and get it out to the population. Because the only thing I've really seen is a lot more funding for food as medicine programs. But my take on them is that they haven't always been plant-based. They're more concerned about food insecurity than food quality sometimes for some of these programs. And so, obviously, I would want to see all of us, particularly physicians, in a position to know about nutrition and to be able to advise their patients, because they're looking to us for help, and we're not always giving it to them, and we're not always eating the best things ourselves.
When you see patients on a daily basis, what are you hearing from them about what really helps them create lasting changes in their health?
I just got off the inpatient service consults and coronary care unit, and I do 3 clinics a week. I make sure that 2 of them are on the west end of Louisville. If you're not familiar with our city, this was one of the many places where redlining was done back in the 1930s. And if you're the west end, west of 9th Street, is the more impoverished, more industrial people working in factories, but a lot of unemployment as some of those factories shut down. So-called rubber town. So there's pollution and high incidence of cardiovascular disease and a much higher cardiovascular mortality than what we have on the east end of the city. So I actually go to the west end, not just for clinics, but we do events where we screen for high blood pressure, cholesterol testing, glucose testing, and now since the prevent calculator, I can talk about that in a moment if you want, where the American Heart Association has changed our risk assessment to include renal function. So we're doing point of care creatinines now as well. So we're doing all that, and every Juneteenth celebration, every neighborhood block party, any big event, African American male walk, the 5K that's going around the country, but it's in Louisville on the West End once a year. We go there and we'll screen 50 to 300 people for disease. And now the best part, if I can put in a plug for Cardinalville, I got to learn to do the little thing with the fingers where to make an L. Okay, the Louisville Cardinals, they actually are incentivized. I think it was supposed to be something like that, but incentivized to see poor people by the state government. So I'm very proud and happy to be here. It's the first time that I've been in an institution that was happy for me to go and bring in the poor, because they knew that they could take care of them financially and it was going to break the back of the accountants. And so so what do we really need? Well, what I hear from the patients is that, first of all, they appreciate the fact that we're there. I have patients come after one of those screenings. had really abnormal tests, come to me and I said, I had another doctor somewhere else, but I'm coming to you because you came to us. That was a nice turn of a phrase. And I think that's what we should be doing as universities and academic medical centers, is going out into the community. But what they really need is a clear understanding and education of good versus bad. That's why all of the things that we were talking about, community education programs, is one thing. They have a food bank, which we do. It's Dare to Care. It's right across the street from my West End clinic. Actually, I have two West End clinics now per week. And one of them's right there, but we need to do teaching classes in there, and because they do have a demonstration kitchen. We have to teach them how to cook food that is very healthy. So we've got a lot of education to do. And right now, people are addicted to the food that they grew up with. They recognize that. We have conversations so that they understand that the stroke and the heart attack and the critical limb ischemia that's going to cost them their foot are things that they ate, and that we could do better. And so, but they're questioning, how can they do that? How can they get their family to help them? Because it's not easy. So it really is a struggle from the entire food system, what they have in the grocery store, what they see on television, what their family has eaten, what their friends are eating, community pressure to not be healthy. Oh, you're too good for us. And so, too good for us to eat the stuff that we're eating. And, we have to change that. We have to change that, just like we did, with COVID vaccines. Worked in pretty good places because we got the word out. Seat belts, they're not 100%, but they actually do work because we got the word out and make it a law. So we got a lot of work to do.
To close off this episode, I wanted to do a few quick fire, like debunking common heart health myths, because I think there's so many out there, and we really believe that misinformation and even sometimes disinformation, there's just a lot out there that it's not helping people get any healthier, and it's even, making them go in the wrong direction in many cases. So what do you say to people who say, one, oh, I'm in my 20s, and so heart health doesn't need to be a priority for me right now?
Really important for them to understand one concept: lifetime area under the LDL curve. Okay, that determines how long you live. And this is why I mentioned the Prevent calculator, which hopefully everyone who's interested can actually put it in their search engine and come up with it, published in circulation. This is why the risk calculator that we now use dropped the age from 40 to 30, because so many younger people are having cardiac events. We need to tell people what their risk is now.
Two, keto makes them feel great, so they'll keep doing it long term.
That's interesting, because keto isn't supposed to make you feel great. You're supposed to make you feel ketotic, which makes you feel a little nauseated, which decreases your appetite. And it really does work for decreasing diabetes. It has been shown to lower blood pressure and weight. The problem is that we have not just LDL cholesterol, but we actually have inflammation. And Paul Ricker at Harvard has been after people to measure your high sensitivity C-reactive protein. He's been asking people to do it for decades. Most of us are not doing it routinely, but if you put those two together, inflammation and LDL cholesterol, there are medications, statins can lower them both, but one of the most effective ways of lowering both is a whole food plant-based diet. Change your microbiome, change the amount, your inflammasome, and your dyslipidemia. And so this is the problem of the keto diet. It raises both your LDL and your C-reactive protein, and people end up with heart attacks and death. They're thinner, but they're gone.
Three, a family history of heart disease means they can't do anything about it. It's just going to be part of their life at some point.
So that's a very common thing. We do recognize that people do have different genetic risks. And so what can we do about it? Everything. That is, first of all, a lot of the family history for heart disease, people don't understand that what is conferred to them has to be a primary family member. So mother, father, brother, sister, child, okay, having something at a younger age. And that would be defined as 60 in a woman or 55 in a man, okay? And the man who has a heart attack at 58 is a tragedy, but it's not conferring increased risk, as far as we know, to the children. Now, the important part of that is, yes, you do have a set of genes, but it really is environment more so. And so your family history is important because your family is eating the food that you ate. And that really is the key. And you can break the cycle by adopting all of the lifestyle medicine principles or pillars, which is a whole food, plant-based diet, good sleep, stay away from substances. I mean, so it used to be in cardiology, cocaine and cigarettes were your big deal. Now it's cocaine, cigarettes, alcohol, crystal meth. It's unbelievable how much heart disease is caused by taking substances, mood-altering substances. So if we were able to be rid ourselves of those, exercise every day, do a whole food plant-based diet, we're going to do so much better.
Thank you so much for taking the time to speak with me and share actionable insights with our audience. We're really firm believers in the fact that it will take a combination of things: community health interventions, government initiatives, accessible health education, amongst other things, to achieve health justice for all. For those of you who don't know, Trio is offering the first 100 individuals to sign up for our new annual plan 50% off. So this is the perfect way for anyone who wants to work on heart disease prevention or reversal with the support of heart health experts to get started. You can sign up now at trio.co/sign up, and you'll be connected with a member of our team to get all of your questions answered. For companies and health systems who want to help us build a future free from heart disease, email us at hello@trio.co. We'll be back with another episode very soon.